Hello and welcome to our program, RX Availability and Access. I'm your host, Stan Rhodes. The abuse of prescription drugs is ravaging lives all around the country, and pills are everywhere. Sometimes the use begins rather innocently with someone just taking pain medications their doctor prescribed. Well, throughout this program, we're going to hear from addicts in recovery about how their dependency began and progressed. Here's one example.
When I was 18 years old, I broke my tailbone and I got addicted to Percocet from the doctor prescribing it to me. And then I got started in Roxy's after that because the Percocet wasn't working anymore. So I went to pain management, got those, and I started abusing those, getting them on the streets and pain management. At first, it was really easy. It was very easy. You just pay for a doctor's visit and they give you what you want. So all really you have to say is that you're in pain. If you have an MRI to show that you are in pain, which most people have herniated discs, they don't feel it all the time, but everybody has something abnormal in an MRI. So, I mean, you really don't need much of anything to get stuff. Doctors should know better. They should know when people are drug seeking. If you're going to be on a pain medication, then you need to monitor it. Because, yes, people have surgeries and things like that, but then they go home with more pain meds that they probably don't need.
Well, Megan had some harsh words for her doctors, but I want to be clear here. No one group is responsible for the problem with prescription drug abuse. There's plenty of responsibility to go around, though. Well, today we will talk about the access and availability of prescription drugs with three experts, and let me introduce them. First, Kathy Paxton has decades of experience in leadership roles regarding behavioral health with state agencies and universities. Her research includes studying the availability of prescription drugs. Dr. Daniel Alford is president-elect of the Association of Medical Education and Research in Substance Abuse. He is also the assistant dean and program director of the Addiction Medicine Residency Program at Boston University School of Medicine. And Dr. Lynn Webster is the president-elect of the American Academy of Pain Medicine and is co-founder of Life Source, a nonprofit foundation to provide education about pain-related issues. Well, welcome everyone. There's a number of directions we could go with this conversation, but I think perhaps the best way to start off is to define what drugs we are talking about. Are we talking about pills? What are we talking about? Who would like to begin?
I can begin. And yeah, we are talking about pills, and I think oftentimes people single out one type of opioid, but there are lots. Oxycodone, and another variety of oxycodone is OxyContin, hydrocodone, which is in Vicodin. So there are a variety of different types of pain pills, but they all are within the opioid class, and they all potentially carry some benefit and some potential risk.
Is it always just painkillers? Are there other items?
First of all, I don't like the word painkillers.
Okay.
You know, these are pain relievers that unfortunately have been characterized now in the media as painkillers because they do cause harm. There have been people that have, excuse me, harmed by the medication. But just to be clear, most of the problem that we hear about is involving an opioid, as Dan has indicated, but there are also benzodiazepines, Valium, Xanax, those kind of medications that have contributed to a large part of the harm.
Can any drug be abused in this way? Kathy?
Oh, absolutely. Absolutely. We have folks abusing everything from, I mean, if you look at addiction with alcohol or any other drug, it just depends on how much the person's taking and if it's not prescribed to them correctly.
Clearly the biggest problem is the opioid class, as Dan had indicated. And we've got some that are long-acting and some that are short-acting. We call those immediate release. We've got drugs called Vicodin, oxys. And by the way, oxys fall into a couple of different categories. You can have an extended release oxycodone, which a lot of people are familiar with as OxyContin, or you can have an immediate release oxycodone, which is just called oxys. And those come in different concentrations, different amount of drug.
Is there one, though, that the abusers are going after more than the other?
Well, the oxys are very commonly, right? For a long time, it was the OxyContin drug. However, hydrocodone or Vicodin or Lorazepam is the #1 drug abused in America today. In fact, it's the #1 prescribed drug in America.
Because we heard Megan talk about OxyContin, and she said, what, All you have to do is go to a doctor and say, you're in pain, have an MRI, and that's pretty much it, right?
Well, I think, wearing my primary care hat, it's difficult as a primary care provider with making that determination. Is the patient's pain real or not, or have they developed an addiction or not? And this issue around drug seeking versus pain relief seeking, they can look very similar because the patient can look equally desperate. And so, they're subjective. The feelings of pain are subjective, and so we need to believe our patients. There's no pain meter that can tell us whether or not they're truly in pain. That all being said, I think over time, as you get to know the patient, you'll start to appreciate that they're misusing their medication. They may be running out early, calling for early refills, showing up in the emergency room. So those are some of the things we look for. But that initial presentation, we believe the patient because there's no other way other than to believe their pain.
Is there a supply issue here, an excess supply of these types of drugs available, Kathy?
Absolutely, and I think initially it was because there was some overprescribing, but I also believe, particularly in the Appalachian areas, there's a sharing culture. So folks are sharing their medications. So it's not just that folks are going to the doctor, but they're also getting them from family and friends. And a lot of the research, whether it's the NISDA survey or other surveys are out, that's the majority of where they're getting them versus the streets.
So is there like a network, a social network of people who are involved knowing what you have and what I'd like to have?
Well, I think that there is real pain. I think if you look in areas that have high cancer rates, if you look in areas where the employment, it's hard work, if you look at, again, Appalachia, where a lot of the rates are high, if you look at the jobs that are there, coal mining, timbering, a lot of those areas cause real pain. So I think there are going to be more pills available because there's true pain. We also have other areas where we are getting folks that are bringing pills in from other states.
I think there are cultures and subcultures and networks that traffic, if you will, more than others. But this is not just a subcultural problem. This is a countrywide problem, and it
is it more than just this country? I mean, it extends the borders?
Yes, it does. Yes, it does. Although the U.S. seems to have a much higher prevalence of the problem, it's increasing in England and several European countries and Asia as well, largely because there has been more available. I mean, we started a decade ago, or maybe 2 decades ago, recognizing that pain should be treated. And as Dan has indicated, this is a difficult challenge for physicians who are wanting to help their patients. The patients have a complaint. Part of our relationship with the patient is to believe our patients. And so it starts off with that belief and our compassion to try to do good. But sometimes that leads down a difficult path that is harmful to the patient.
So are doctors writing too many prescriptions?
There's no question that the number of prescriptions being written has gone up. And I agree with Lynn. I think it's in response to trying to relieve our patients' suffering. And opioids do work for a number of patients, but it's impossible on that first visit to know which patient is going to benefit and which one isn't. And so I think, and oftentimes opioids are the last medication to try, and so you're left with, we've tried everything else.
What can be used before opioids?
Well, I think some of the, what we call non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, and medications like that, acetaminophen, which is Tylenol, are certainly medications that I would start before starting an opioid. But usually by the time you get to the opioid, you've tried all those other things and they haven't worked. And so I think there are sometimes unrealistic expectations both from the patient, but also from the person who's prescribing that this is going to work, and if it's not working, you just need more. Or, doc, it's not working, I need more. And you start to see this escalation. And that's kind of part of the increase in prescribing that's going on, is this attempt at relieving suffering with kind of the last thing that you're trying.
Is the problem here more than just with doctors, though? I mean, there's more people seen as when a patient comes through a door. Are there other ways that other people are involved here?
Well, I'm not sure I understand exactly your question, but certainly everyone is responsible for the problem. This is not just a physician overprescribing issue. It is a consumer issue. It is a family issue. It's a religious issue. Every part of our culture has contributed, either because of their lack of interest in addressing the problem or because they've been very active in facilitating the misuse of the medication.
So there are many spokes in this wheel. Kathy, you had mentioned about people sharing pills. What do people do with excess pills that they have?
Well, they keep them. They keep them for many years. They'll share them just in case that they have a problem in the future or someone in their family does. Again, if you come from a sharing culture, that's very prevalent. But also, folks will just keep them around their house. We've been working with a lot of employers, such as realtors, different individuals, to have folks to lock up their medications. People will flush them, which damages the water systems. There's a lot of education around safe disposal that folks just don't realize. They'll keep them until they're out of date. But there's a lot of, I think, personal responsibility that's key here in safe storage, but also telling your doctor that you don't need the level of medication that maybe they are prescribing, or being satisfied with taking ibuprofen or other medications, because so many people feel that when they go to the physician, they want something stronger, and they're not willing to start. So that puts the physician in a bad position as well.
Well, is there a prescribing issue here where perhaps a patient would perhaps do well with maybe, I don't know, half a dozen pills, and sometimes they're given much more than that?
Yeah, and I think that is absolutely an issue. When you go to the dentist and you're given, 2-week supply of opioids as opposed to 3 days supply, or post-operative. And I think there's a lot of education going on now around, how long should this pain last? Because these are really, you're talking about acute pain. This is pain that should go away once the person heals, as opposed to, the chronic pain where people have pain that goes on for months and months and years and years. So I think there is overprescribing in that setting, in the kind of acute pain setting, and that is, something that needs to be addressed.
And Dr. Webster, you mentioned that there are many segments of society that are involved here. Do insurance companies fit into that wheel of responsibility? In
a significant way, and in multiple different ways. Each prescription, you have a copay. And so for a physician who's trying to help their patient, you want to give them enough medicine to carry them through. If it's an acute episode like Dan has indicated, or if it's a chronic pain patient, you want to give them a reasonable amount for as long as possible, so they only have one copay, because these are very expensive if it's something you do every month and it's only one of several different prescriptions you have. If a copay is $25, you've got 5 drugs or 5 different prescriptions, that's $100 a month. That's a lot of money for a lot of people. And so if you have a condition which you realistically think they only need for 3 days, that's $25 for 3 days, but then they need another one. That's another $25. So the insurance companies don't help us solve this problem, because they, and frankly the pharmacies too, because the pharmacies have a cost of filling a script. So all of that cost issue gets packaged into the barriers of us managing the prescription of the medication in the most safe way.
Wow, interesting. Who is most at risk right now? What segment of society? Is there an age bracket? Teens, 20s, 30s?
I look at a lot of young people that are using. They've told us in focus groups that that's their drug of choice, because they can't smell it on me when they're stopped by a police officer. A lot of our folks, a lot of our kids aren't using alcohol as much. They're strictly using pills. It's easily accessible. They start in middle school taking their brothers or sisters' medication that they've used for ADD, ADHD, or it's just availability and accessibility for them.
I think there's also a false sense of safety with these medications.
Absolutely.
So that it's a prescribed medication, so it can't be dangerous as opposed to something like heroin or cocaine where it's an illicit drug. And so I think there is this false sense of safety with it. And oftentimes patients come to me and say, boy, I didn't realize that I could become addicted to this or that it was going to be a problem for me.
Well, then, is it easier for doctors just to write that script as opposed to trying to take the extra 5 or 10 minutes or whatever it might be to explain what can happen with this?
Yeah, no, I think it is easier just to write the script, but I think
Is that becoming part of the problem as well?
Well, I think it is part of the problem, and it actually also addresses the issue around is it just the physician's responsibility? And I think it does require a team approach, and that is, when I have a diabetic patient and I'm starting them on insulin, it's not just up to me to teach the patient about the insulin
Who
and
else
safety.
is involved in the team?
Yeah, nursing, medical assistants, sometimes a social worker, a case manager. So I think it really needs to be a team approach because this is a lot of work. There's no question about it. To prescribe these medications safely and continue to prescribe for the patients that are being helped, it requires a lot of work, and there's no question about it. So I think a team approach is critical.
Kathy, do we go to, and here you're surrounded by 2 doctors, but do we go to doctors with the mindset that we're going to get a drug, we're going to get a pain, not a painkiller, but a pain reliever?
If I pay my copay and I see my doctor, I expect medication in return. I could stay home and take Tylenol. So that's that re-education and that personal responsibility that I think is key. I think that when we go to the dentist and they prescribe us Vicodin and give us an extra script, we need to say, I don't need that, that's not necessary. I think it is, again, it goes back to personal responsibility, but it's educating the community as a whole that we don't need the medications. And when we have heard so many marketing messages by the drug companies, you can't turn on the television that there's not something that's going to make you feel better, live longer, be smarter. And we're bombarded by those messages constantly that creates this norm of I need appeal for every single thing that I do, as a person living in this society.
Wow. Well, we have talked a lot about the problem of RX availability and access, and after this short break, we will talk about doctors with our doctors and the training they receive regarding addiction.
This yellow one is for my postpartum depression. This one, sciatica, whatever that is. I got these after my hysterectomy, or my prostatectomy, or stomectomy. And this guy is for the pain from my last hip replacement. And this orange one is medical.
For teens, getting drugs can be as easy as opening your medicine cabinet.
Millions of teens have found a whole new way to get high on drugs that are all over the neighborhood. Legal drugs they can get anytime they want, for free, in almost any home in America. Cough medicines, prescription painkillers. Last year, more teens intentionally abused them than ecstasy, meth, and heroin combined. Learn how to talk to your kids about the drugs they get at home at drugfree.org.
Welcome back to our program, RX Availability and Access. Well, our 2 doctors on this panel, Drs. Alford and Webster, are highly trained in the science of addiction, but not all medical professionals receive that kind of training. Why is that, doctors?
That's a good question, and I think it is changing. I think we are seeing more inserted into curricula, both in medical school and in residency training, but there's no question there's not enough of it, and we're a little late in getting it in there. And the curricula now in medical school and residency training is quite full. with lots of other things. So you're trying...
It keeps getting fuller, I'm sure.
It gets fuller
more and more
fuller.
things.
Exactly. It gets fuller. And so you're asking to remove something to put something else in, or try to be creative in ways to insert it. But it's identified as a major problem, and it needs to be inserted.
1/5 of the population is vulnerable to an addiction. 1/5 of our population. So 1 out of 5 individuals, 1 out of 5 people out of a family, 1 out of 5 people in your church is at risk of developing an addiction. I think we've missed the boat by not making it more of the hardcore curriculum in both the medical schools as well as in the residency programs. And there is a lot of effort. Dan's a part of an effort, and a lot of us are working towards more exposure to the need of better education in addiction medicine.
So where should we start? What needs to be done? What's the first thing out of the box that needs to be taken care of? Doctor shopping? Where do we go? Where do you begin?
That's a good question, because I think there are a lot of needs up there on the top. And I think understanding risk, which patients are at risk, and we don't know for sure who has 100% risk and who has 0% risk, but everyone has some risk, but there are some risk factors.
But are doctors trained about addiction, identifying people who are in the throes of addiction, or?
Well, I think that's starting. I think that's starting. And again, as I'd mentioned about pain being subjective, it's also not always so clear whether or not a person is addicted in front of you as well, especially when they're addicted to a prescription medication that you're prescribing. That's very different than when someone's out there using cocaine or heroin and they have a clear addiction. But oftentimes patients who are on these prescription medications, they have true pain, but yet they've maybe also developed an addiction. And sometimes they look, it's hard to distinguish.
Yeah, let's be clear, though, that there are different terms, or many of us use these terms differently. Addiction to one individual may be not addiction to another individual. In fact, most of the medical profession cannot agree upon what is addiction. So you've got somebody who will use an extra pill, let's say, for their pain, because they're really trying to get out of pain, but it also makes them feel good at the same time. Many people will say that person must be addicted. Many others of us will say that's not really what's driving the use of the medication. Driving the use of the medication is to get out of pain. But there's a lack of consensus, there's a lack of science in the definition of what really is an addiction. This contributes to the problem.
So that's what's kind of keeping people from getting together and starting to work on the problem?
Well, I think the lack of understanding, the lack of the science, and the lack of an agreed upon nomenclature, that is the language that we use to define what kind of behavior, what kind of conduct really is somebody who develops the disease of an addiction. And the other problem is the word addiction has so many legal connotations. You think of somebody who's an addict and you tend to think of them as subterranean people, and they are not. They're human beings, just like somebody with a mental health disorder. It is a mental health disorder, yet we treat them in a much lesser way.
What word would you substitute, or words would you substitute addiction? Would you use to substitute?
Well, there's a movement well, actually the movement is to use addiction now for all aberrant behaviors. And I have some trouble with that because of the legal implications, because of the social implications with the term. But others, and I use it, I don't know, I'd like to hear what Dan and Kathy think, but I'd like to see an opioid use disorder. It's using it, and it's a disorder of the use of the medicine, and it could then span that full spectrum. But really, for your audience, it's important that some behaviors that are always termed addiction are probably not addiction. They're problematic, they can be harmful, but they may not be in that classic term addiction.
So who's in the audience of the target audience that needs to be trained, needs more training? Kathy?
I think everyone. I think our communities at large need to be trained and educated. Our parents, the youth themselves, understanding the harm that prescription drugs can do. But again, back to the physician, for me, I believe that most of us do what our doctors tell us to do. And I think they have a particularly high burden of providing us with good education, and but they have to be educated. And in the work that I've done with physicians, that has been the overwhelming issue, is the issue of education, not receiving that as a resident, or maybe they would have just a short rotation in dealing with folks with addiction. But for me, it is any allied health professional, whether it's the nurses who are providing, they're the ones that provide a lot of the patient education in the doctor's offices as well. But again, I think it's the communities at large.
So I think diagnosing the addiction is just one piece to it. I think what Lynn brought up is there's a spectrum of problematic prescription taking, and it could just require more education. The patient needs to be educated about that these medications need to be taken exactly as prescribed, or all the way to the the other end of the spectrum, which is addiction. And we don't need to wait for the definitions to be figured out and everything else to start educating physicians, because the problem is there, and it's actually no different than anything else that I do in primary care. It's this risk-benefit equation. That is, if I prescribe you a medication for your blood pressure, but you're having terrible side effects, then I'm going to change the medication, even if it's helping your blood pressure. Well, it's the same thing with these medications. If the person's being harmed, that is, that they're taking more than's prescribed, they keep running out early, they're slurring their words, it's too risky. Whether they've got an addiction or not is another issue. But the bottom line is the medication's too risky. I need to try something else. And I think a lot of the education needs to be around how do you communicate with patients about risk, and how do you communicate with them about, I believe you have terrible pain. That's not why I'm stopping the medication. It's because of the increased risk.
I'd like to add, if you don't mind, that it's not just about the physicians educating or the physician being educated. It is a cultural problem. And the culture has to be educated. Our churches, our communities, our families, all of our relatives and friends need to take a look at this issue as a part of their problem as much as it is a part of the medical problem.
Right. But let me come back. As a primary care physician and as a gatekeeper, are you being trained in the areas of knowing that somebody is doctor shopping? Do you have that training?
Yeah, so that training is ongoing now.
Is that something, though, that you got through your college that was automatically there? That's something you've learned how?
It's something that I've learned, and it's something that now it's become more formalized, and there are more training programs out there. And we run training programs in our state that fill within 48 hours. So there's clearly a desire to be trained in how to do this. The other issue is, how do you do the training? And you could train 200 people in an audience and give them a bunch of lectures, or you could work with 10 physicians and teach them how to communicate, how to do the skill part of it, which is probably the most difficult part. You can imagine where a patient is sitting in front of you and they said, well, I've tried everything else, my pain is terrible, and I need more of this medication, and I'm trying to teach them that they actually need less or none of this medication because it's not working. And that's a long conversation and one that's difficult to have, and I think physicians need the training in how to do that.
I'm still hanging on your words, 1 out of 5.
Yes.
We'll have this problem.
I hope everyone who's listening to this program hangs on to that too, because we're all at risk depending upon our environment. An environment means who we're with, mostly the stress in our life. And if you are a pain patient and you have a moderate to severe degree of pain, there's really nothing comparable in stress. It impacts your finances, it impacts your ability to carry out daily activities, your quality of life. And as a result, that increases your pain, and you are at greater risk then to display the aberrant behaviors, to begin to look like you have a problem with the drugs, and frankly, even begin to have a serious substance abuse problem.
Wow.
And I just want to highlight that it's not all about risk and harm. That there are patients that benefit and do well. Their pain is improved, their function is improved, their quality of life is improved. So if it was all kind of harm and risk, we could just get rid of these medications. That would be an easy fix. But the bottom line is it does help some patients who are suffering. And so it's up to us as primary care docs or whoever is prescribing to kind of weigh the risk, weigh the benefit, and figure out what's in the best interest of this particular patient. So there is some benefit. I want to make sure that's
Yeah,
Very good.
Dan brings up a really good point, because you know, when we address this problem, and certainly in the media, it's almost always conflated. That is, two separate populations: the population that are obtaining the drugs illicitly, you know, a lot of the kids that you were talking about, Kathy, earlier, and the pain patient. Now, some of the medicine can go from the pain patient to the illicit user, of course, but how we solve the problems of those two different groups are entirely different, because their motives are entirely different.
It's going to take many different resources and many different ways to go about this.
I believe so.
Okay. Well, recovering addicts can reveal a lot about the scope of the problem with RX availability and access. Andrea used to buy pills from what some may say is an unlikely source.
Right after I had my son, when I was 21 years old, and right after I had him, I, of course, was prescribed Percocet. I started out just taking like the Vicodin and the Percocet, and I got up to taking those like 20 or 30 times a day. I was buying them from a person that I don't know where he got them, but he was obviously, had a pretty direct connection to them, because he always had them. I started meeting with different people that they went to the doctor themselves. A lot of older people go to the doctor and sell their pills because to supplement their income. These old ladies that just, you know, the cute little old ladies that never do anything wrong, or, you know, these major drug dealers, and they would literally get their medicine and call around and let them, you know, get calls out to people to let them know, like, hey, I got these. And then the other major way was people doctor shopping. I knew one guy, he went to 5 different doctors, you know, and so I mean 5 times a month he was getting 180 or 240 of these pills. It's really just manipulating the system and finding loopholes. Pay for one with cash, tell them you don't have insurance, and then go to this place and tell them that you do.
Andrea debunked some myths about what a drug seeker may look like. So the question is, do doctors think they know what an addict may look like? Do we have an idea? Can we put them into a category and say, well, this person is a drug addict?
The answer is no. The answer is no. I mean, clearly there are some obvious cases where a patient is just so out of control and not doing well that it's obvious to people around them. But I think if you count on that, you're going to miss a lot of people. And so I think it's really important to monitor all patients. And what do I mean by monitoring? Well, I mean, you know, doing urine drug testing. That is to make sure that in their urine is the drug that you're prescribing and that there aren't other substances that you're not prescribing. I think it's important to do pill counts. That is, when the person comes in for maybe a random visit, you call them in, you bring them in, you should be able to count the pills, and the exact number that should be there. And then thirdly is a lot of states now have prescription monitoring programs where, as a physician, I can log on and I can see where my patient has been getting their prescriptions, from which sources, from which prescribers, from which pharmacies, and how many in the month. So, you know, these are all tools not to catch people and not to say, oh, you're an addict, but to keep them safe. For me to say, boy, you know, I've noticed there are some problems here. Let's talk about it, and to get into a conversation. Maybe they've got an addiction. Maybe they're just taking more because they feel that they need more for their pain, and trying to sort that all out.
But that's going to be a pretty difficult conversation to have. If you find somebody that you've given them 40 pills, and when you call them in, they should have maybe 20 at that point, and they only have 3 or 4, what do you do? Yeah,
oftentimes it requires re-education one time. To kind of explain how people die from these medications all the time when they misuse them, when they take extra ones, and that I really don't want them taking any extra ones because it's not safe. And if they continue to take more than I'm prescribing, I'm starting to feel that they've lost control of that prescription. And again, it's not whether they're addicted or not, because they may be, but it's that it's become too risky for me to continue prescribing and to keep them safe, because part of my job is to do no harm. And clearly, I can't prevent this person from being in harm because they can't control that prescription.
Right. Kathy, are there barriers for physicians getting into these kinds of conversations?
Absolutely. I think it's an uncomfortable conversation to begin with. Yeah. And, you know, something that you keep talking about that I think is so important, and I usually hear this from primary care physicians, they do have that doctor-patient relationship, and it is establishing that relationship. A lot of our folks that are doctor shopping or they're going to different physicians, that hasn't been established So a lot of states are trying to put that in place, whether it's in legislation or not, requiring, more of a burden on that physician, I think, to establish that relationship before prescribing. Folks are receiving prescriptions online. They may not see a doctor face to face. Some of the things that I didn't realize that was even occurring. So for me, it's establishing that relationship, that ongoing relationship, and he gave you all of the educational tools that docs need.
But this seems like it involves a lot of time, Lynn.
Oh, it takes a lot of time. You know, it's so often, I have said, and several of my colleagues have said, it takes 30 seconds to write a script. It takes 30 minutes to counsel a patient on why maybe they shouldn't have the medication. And our healthcare system reimbursement structure doesn't help doctors take that extra time to counsel. They don't pay for, often, they don't pay for the behavioral medicine support that our patients who have chronic pain need. We know with good behavioral medicine support that the amount of medication can be reduced and that there tends to be less abuse. So some of it's our healthcare structure in the reimbursement, because clearly doctors can't do the right thing in 3 minutes or in a 10-minute visit.
So do many doctors just simply avoid these kinds of conversations just because the time inventory is not available?
Unfortunately, I think that's true. I think that it is too much of a burden, and there is a lot of trust. Doctors, that's part of our relationship as doctors to patients. We establish a trust with our patient. If we don't, we are not doing the right thing. We cannot provide compassionate care to patients unless there is that validation that what they say is correct. So we have to break a validation. We have to break our barrier, our relationship with them if we threaten that relationship in some way that they may not be telling us the truth. I mean, it's an adversarial situation and not comfortable and can't be done in 10 to 15 minutes.
A couple of things I wanted to follow up on, and one has to do with when people end up with pills that they don't need. Do people have a way of returning these or giving these back or disposing of them in a proper way?
Absolutely. There has been push by ONDCP, CADCA, a lot of different prevention organizations, to DEA is a partner in that as well, to do prescription drug take-back days. And for folks to be able to bring in and dispose of their medications. There's certain best practice around that it's a secured spot, that, but yet folks don't feel threatened when bringing in the medication. But also, I mean, like Ed referenced earlier, even just keeping it out of the water systems is a benefit. But I also think probably the most positive thing that comes out of that is folks are becoming aware that they shouldn't keep them, that they should either keep them locked or dispose of them, not to keep a hold of them, whether it is for safety and security reasons for that senior who's had a hip replacement, so that folks won't be coming into their homes and taking the medications, but also it gets communities acting and fighting against this problem. So it creates that awareness and readiness to do something.
What about the topic of pill mills? Any comments regarding that? It's not a specific question, it's just putting that topic out.
Well, you know, the classic description of a pill mill is a physician that is just writing scripts, not examining a patient, and providing the script for cash, and sees a lot of people a day. It's not medicine. It's not the practice of medicine. It's really it is really just dealing in drugs, and they have contributed to a bad image about the field, our specialty. They certainly contributed to a large supply of drugs used illicitly in the community, and we need to do away with pill mills. Now, the problem is in some cases that legitimate docs who are prescribing large amounts to legitimate patients are viewed to be pill mills. And there is that, it's just like trying to define somebody who is an addict versus somebody who's abusing or maybe misusing. There's not always a clear line. You know, and so it's hard to, it's sometimes hard to identify.
Is this a growing problem, though, in this area? I mean, in the United States?
Well, pill mills have become a big problem, particularly in the state of Florida. And that was a big problem, but there has been a major crackdown in the state of Florida, and a lot of the drugs have been transported. People have come from the north, from Kathy's state and other states in the north down here in truckloads, basically buses to come down and haul drugs up. But fortunately, there's been a lot of progress in that area, and a lot of those pill mills have been, I mean, the real pill mills have been closed. And so we do have to watch out for that.
I think Lynn brings up a very good point, and that is there are physicians who say, I don't prescribe opioids. And so you
that
can...
they will never write a script for it.
I don't write a script for it. That's what some physicians say, which I think is wrong. But what that results in is that there are certain physicians who are willing to treat chronic pain, who are willing to prescribe these medications, who end up taking on the majority of these patients. And so they tend to be higher prescribers than others. And so it's not evenly distributed because there are some physicians who just say, I don't do it. They don't say that about, I don't prescribe insulin or I don't prescribe other medications. So I feel that chronic pain and medications to treat chronic pain is just like anything else that I do, that some patients will benefit and some won't. And I would never say no to a medication that has some benefit for some people, but there are some who do that. So I think you do get a sense that there are some people who are overprescribing, but really they've taken on the burden of treating most of, a lot of these patients.
And I think you have to be really careful when states have the prescription drug monitoring systems that their thresholds aren't. They're looking at those docs to where if you have a doctor who is constantly doing knee and hip replacements or treating cancer, specializations in those areas that there's a high degree of pain, you have to make sure that you're not pulling those individuals as those docs that, are over-prescribing. And there's a tendency to do that, to set those thresholds at those rates, and you're just looking at the number of pills prescribed. So you have to carefully select the thresholds in which you're developing those reports.
Well, for addicts, their lives often revolve around finding their next fix, and prescription drug addicts are no different. Here's another example. Patricia, her entire life revolved around them.
I had excessive jaw surgery, and my surgeon referred me out to pain management, and I got hooked. I needed it 8-10 pills a day so I wouldn't be sick. My family would plan something to go out of town and do family stuff, and I could never just up and go. I hated that I had to try to go find something first so I wouldn't be sick. I did have to try to buy from others when I was out, because I was out so quick, give them to everybody else. And so when I ran out, I would have to go and find them on the streets. If I would have known that I was going to, become hooked on drugs, prescription drugs like that, I would have never gotten a surgery, ever.
Well, Patricia mentioned that she did not want to be sick. What kinds of sickness comes from not having pills?
Yeah, so when you take these medications, opioids, the body becomes physically dependent. That's a biological property of the medication. There are other medications.
Even when you're just taking the initial amount that you were prescribed?
Well, over weeks.
Okay.
Over weeks, if you're taking it consistently, your body adapts so that it becomes physically dependent. And there are some blood pressure medicines that I prescribe that people become physically dependent on too. That's not addiction. That's just a biological property of the medication. But when people start to use them over and over for long periods of time, yeah, they develop physical dependence. That is, when they stop taking it, they get sick. They go through withdrawal. And with opioids, withdrawal is nausea, vomiting, diarrhea, and a lot of the kind of things that patients with heroin addiction will go through. That is withdrawal in that regard. So when we stop these medications, we need to taper them if someone's been on them for weeks, so that they don't go through that withdrawal. The problem is when someone is truly addicted, they can't take it in a scheduled way. Okay, they need more and more and more, and they run out, and they go through withdrawal, and they get sick. and then they go out and buy more on the street to kind of feed that to treat that sickness, because it feels like the worst flu that you've ever had.
So it's not just an imaginary sickness. It is a real sickness that the body is wanting.
It's not a flu, but you feel like it's the worst flu in your life. In fact, many people, it's rare for somebody to be seriously harmed from an opioid withdrawal by itself. We tend to say you never die from it, you just wished you would die. It is really, really a severe problem. But you know, this is an important topic because so many young people who get access to these drugs and start taking them on a more regular basis develop that physical dependence that Dan was just talking about. And then they may choose that they want to stop. But now they start to feel ill and sick. So they go out looking for a replacement because they've been taking illicit drugs illegally. These are criminal acts that they've been conducting. And now who are they going to turn to get help? They've never sought a doctor to get the medication. Now they're buying it from the street. And so they're kind of trapped. Either they tell their parents and family that they've been committing criminal acts, or they go to a confidant doctor who's willing to help them, and it's very difficult for them to do the latter. So they're trapped, they're called addicts, maybe they're physically dependent, and that's all it is, or maybe they have an addiction. It's hard to know. Nevertheless, it is a very troubled time.
Is it more than just a physical dependency when people start taking these drugs?
Well, it could be. It could be there's a psychological dependence. It could be that they're using it to feel high. But after a period of time, oftentimes we lose that, or an individual will lose that high, that good feeling. They just avoid the low feeling. So they're trying to avoid the withdrawal. And when we get to that point, when somebody gets to that point, they're really trapped. They need medical care. That's why the disease of addiction, physical dependence, abuse, these are medical problems that need medical solutions, and they do not need to be criminalized.
And they need plenty of time to get over.
They need access to the right care. Yes.
Usually we think of people who use drugs illicitly on the illegal market either to feel high, to feel good, or to feel better. And to feel high is someone who's feeling totally normal, but they use with their friends, and they realize that these medications also make you feel high or euphoric. But some patients, some people who use these drugs illicitly are depressed or anxious, and they realize that when they take this medication, they feel better. And so those are probably the two main reasons why people would start to fall into the trap of misusing these medications.
I want to bring you back to a question I somewhat asked earlier as a primary physician and gatekeeper. How do you screen your patients for such things as this?
Yeah, so
have you set up some sort of a program that you have throughout your practice that everyone must follow to do this?
Right. So when I think of screening in this area, I think of two major areas. One is screening for risk of misusing, not necessarily addiction, but misusing that opioid prescription. And Lynn actually developed a tool called the Opioid Risk Tool, which is a very simple questionnaire that you can ask patients, and you can score them based on their answers as to whether they're kind of low, middle, or high risk. And then you can decide how much monitoring you're going to do, or whether or not they're too risky to even prescribe this opioid. The other screening that I do is just screening for unhealthy substance use, and I mean alcohol and drugs. And the reason why I do that is because I want to know if they're using something that's going to interact with the medication I'm going to prescribe. Because although there's a lot of overdosing going on, unintentional overdosing with these medications, a lot of it is multiple drugs being taken at the same time. It's not just one drug. And so I want to know before I write that prescription, is this person using something else that's going to interact, or are they drinking unhealthy amounts? And if they are, then I need to educate them, and they need to make a decision whether they're going to change that behavior so I can safely prescribe, or no, they'd rather continue that behavior, and then I can't prescribe safely.
We know that people who have one substance abuse problem are 7 times more likely to have another substance abuse problem, and that's why what Dan's talking about is very, very important, particularly in primary care. And it all falls back to the mental health disorders. Almost no one has a substance abuse disorder without mental health disorders as well.
So you tie the two together.
They're almost always. It's very, very uncommon for us to find somebody with a substance abuse disorder without one or more mental health problems in addition.
Is there a commonality of a trigger that causes them to go this route?
Well, to go the direction of, yeah, I think that the mental health problem, as Dan was saying, depression, usually I see anxiety. General anxiety disorder, post-traumatic stress disorder, ADHD. 70% of people with ADHD not treated become substance abusers because they're trying to feel normal.
Self-medicate.
They're self-medicating. That's
Absolutely.
exactly right, Kathy.
Absolutely.
All they're trying to do is get back to feeling normal and being able to engage. Their mental health problem keeps them from doing that.
That's what our kids tell us. They use substances to escape, or
What
to
are they trying to escape from as teenagers?
abusive home, grades, stress, and the list goes on. I mean, that's when we talk to folks on our prescription drug line, it is absolutely, it's to feel better, and it's escapism. Those are the 1 and 2. And it isn't, like you said, in most cases, it isn't to get high. It's avoidance of pain, but it's emotional pain.
It's emotional pain.
It's not the physical pain, and that's where we find a lot of the abuse.
So Dan, when you have a teenager come into your office versus maybe somebody in their 30s, 40s, something of that nature, is it more difficult to deal with them? Is there an honesty issue? Is it just relational problems that come about?
No, and as a general internist, I treat adults, but I do treat some young adults who are probably developmentally in the adolescent range, especially when they have a substance use problem or a mental health issue that hasn't been addressed or treated. But there are different questions that are asked of adolescents because, or young adults, because you know, different amounts of drugs are dangerous for them, and also there may be a reluctance to disclose their use.
Is there an age segment that is more prone to being subject to the addiction?
Well, yes. The statistics say under the age of 30 is where we see most substance abuse appear.
Under the age of 30?
Under the age of 30 is when most substance abuse occurs. That's different, though, than the risk of unintentional overdose deaths. The risk of dying from a prescription drug is greatest in middle age, from 35 to 50. And that's largely, I believe, because higher doses of drugs are being prescribed to that population. There's a lot of stress going on, and that they end up having benzodiazepines and other drugs as well. And so the drugs are being pushed up to try to restore their life, their quality of life. And there's a lot of impulsivity at that age to try to get back to their life before pain. Now, in the adolescent, under the age of 30, usually under the age of 25, it's really experimenters who have a genetic vulnerability, so they're exposed to an opioid. And just like in alcoholism, we have different types of alcoholism. Some alcoholisms, with the first drink, leads to a path of severe alcoholism. For other alcoholisms, it'll take a decade, several decades for it to develop. This is true for opioids as well. Early vulnerability, or I should say the early addict, surfaces below the age of 25 who have really a strong genetic propensity. Later in life, we see a different pattern based upon mostly stress and environmental induction.
A question would be, what about prescription monitoring programs? Do they work?
I find, yeah, they do work. They work in two main ways. I would say 99.9% of the time, what they tell me is that the patient is not doctor shopping, that they're only getting a prescription from me, and that's reassuring and allows me to give good feedback to the patient.
And you feel honesty in that?
Well, I feel that I have trust in the system.
Okay.
And the system is the prescription monitoring programs are basically data is entered by the pharmacies into a data center where that data then becomes available to me, so I know exactly where the patient's been getting their prescriptions. Now, there are issues about people getting prescriptions filled at other states, and now some states are starting to cooperate where they're sharing data. But it would be nice if there was a national database where I could look to see wherever they may be getting a prescription. But it is reassuring. But there are times where I've identified patients who have gone to multiple prescribers, multiple pharmacies, and again, I have a conversation with them, and I want to know what's going on. And oftentimes, when you find a patient like that, they're at the point where they're willing to disclose that they think they've lost control and they need help. And that's when you make an addiction treatment referral.
And federally, there is a push for that interoperability of the states. I think there's about 20 states that have signed on for a national prescription monitoring system so that you can do just that, particularly helpful for border states in folks going back and forth and writing prescriptions. And also, if you can produce some of those unsolicited reports, now in most states, it is the police department or it is someone going to the system and requesting the number of pills being dispensed. They're looking at it with regard to legal matters. But having the ability to provide unsolicited reports that can just help doctors, that can provide more information to them on a regular basis, even self-monitoring. Do you realize this is how many pills? It's education, and it should be before it's punitive in nature.
And it also depends on where you're practicing. So if you're in the emergency room and you have no relationship with this patient, you'll find many more problems on the prescription monitoring program. That is, people that have gotten prescriptions from multiple sources. When I've got a patient who I've been following for years and they're on the same prescription, the same dose, doing fine, it is very rare for me to find any kind of problematic behavior. But clearly, when a patient comes to me for the first time and they say, my doctor retired and I'm on this dose of prescription, it's very useful for me to look up the prescription monitoring program and verify that that's exactly what they're getting and they've been taking it, getting it on a monthly basis.
Well, folks, we've reached that time where we're at the end of our program, and I'd like you to perhaps give me some final thoughts. Dr. Webster, I'll begin with you.
Well, we're talking about a prescription drug problem in the country, and it really is a crisis. I think that if we're going to turn around the problem, if we're going to reverse this trend, it is going to require everyone to participate. This is not just a physician issue. It's not just a patient or law enforcement or government issue. This is going to require every person in every community to understand, first, these drugs are powerful, serious drugs that can kill.
Very good.
Okay.
Kathy?
I guess for me, I look at this as being a multi-generational problem. I have kids right now who have absent parents because of their substance use, particularly since this prescription drug epidemic. But now we have such high rates of drug-exposed pregnancies that it's affecting future generations as well. And I think the national averages is about 4% of women, and a lot of the states that I work with are above 20%.
Wow.
So,
Dr. Alford?
Well, I think we've identified this is a very complex problem. So I would like to say that when there's a simple solution proposed, that people be suspicious and be skeptical. Simple solutions like, we shouldn't prescribe this medication when there's a class of medication. So if you outlaw one, someone will start prescribing a different one. Or, cutting off a dose limit, or how long we can prescribe these medications. Those are simple solutions to a complex problem, and they're going to fail, and they're not going to really address the key issues.
Unfortunately, we are out of time. I wish we could continue our conversation. We'll leave you with some internet resources you might find useful, and you can find them on the website for Multi-Jurisdictional Counter-Drug Task Force Training Program at www.mctft.com. Just click on Broadcast and Videos, and then on Resources. On behalf of Kathy Paxton, Dr. Daniel Alford, and Dr. Lynn Webster, I'm Stan Rhodes. Thanks for watching RX Availability and Access.